So welcome to the North Metro Fire Rescue whole blood training rollout. So this will be the first training that we have of our whole blood training, which is going to have some video training, some in-person training, some emails, and a whole stack of things coming out. This is going to be the first part. That'll be all hands and initial familiarization of the concepts that we want to talk about, and get you ready for the in-person training that we have coming up later this month. For the context, the all hands training is going to cover what you need to know when you're just working in the field and seeing patients who may be candidates for whole blood and how to get the process going. The actual blood administration details are going to be the responsibility of the SAM officer or out-of-class SAM, or if we have a mutual aid response, it'll be the responsibility of the person coming in from the other district that would have the blood. So more on those details later, but this is basically what you need to know about whole blood to get the training started. So first off, let's talk a little bit about why whole blood, why we're using low titer O positive, talk about different patient types, shock recognition and shock index. We'll talk a little bit about transfusion reactions and treatments. We're going to cover some additional treatment options for hemorrhagic shock. I'm going to go over just broad strokes on the equipment, but we're going to do a lot more of that hands-on in the training. We're going to talk about consent because that's an important part, and then a little bit of logistical response and documentation considerations. Hopefully we're going to get this video done here in about 20 minutes or so this will be a quick one. So first off, why whole blood? And this is one of the comments that, that's come out on some other agencies that have started this. I believe this one is out of New Orleans. And the comment is, well, I work in the city. I'm never more than 10 minutes from a trauma center. Our patients can wait until they get to the hospital. So the problem with that is that every minute of delay in whole blood administration decreases mortality between 5 and 11%. So the golden hour really is kind of a made-up concept that is a convenient way to think about trauma care, that they need to get surgery and care within an hour, but really it is it's a time-dependent, gradual decrease in survival over time from injury. And so moving up the time that patient gets blood, if they need blood, will increase their survival. And so if you're the patient's bleeding out, would you like to prolong your hemorrhaging experience or get the blood faster? That's kind of the way to think about this. And so this can get things to the patient a lot faster. And when we look at bleeding deaths in the curves of mortality, the bleeding deaths happen early on. And this isn't just the patients who bleed out and go to a cardiac arrest, but also includes patients who go into irreversible shock. So basically they lose so much blood that they get end organ damage that even after you resuscitate them, they don't survive that. And that covers patients in these first days. And this early transfusion of blood seems to reduce that significantly. So what do we have? We're going to have low titer O positive as our mainstay. And what does that mean? So it's a 500 ml bag of blood. It is all of the blood components together, just the way it comes out when you donate blood. It's stored cold, and it's blood type O. Now, it could be O positive or O negative. The ideal blood type that we'd want for donated blood would be O negative, but that is so valuable we can't actually get that in the pre-hospital setting. They use those components in the hospital because those are the universal donor components, and so those end up getting used, and it's very, very challenging to get, but instead we'll have O positive blood, and we'll talk about that. Low titered means that the concentration of antibodies within the blood that could react to the patient's blood is very low. Leukoreduced means that it is treated to remove some of the white blood cells that again limits that immune response of the donor blood to the patient. It's filtered in a way that saves the platelets because we really want to have the coagulation factors there. It's collected in an anticoagulant, which we'll talk about a little bit later. That's important when we think about things like whether or not we're going to give calcium to our hemorrhagic shock patients. And basically this will stay fresh for 5 days. Fresh or up to 21 days with cold shelf life. And because of that 21 days, that gives us basically a week with every unit of blood before we have to turn it into the blood bank to swap it for a fresh one. And then that gives the blood bank time to administer that whole blood somewhere in the hospital for other patients who would need it. So who are our patient types? This is going to be for patients in hemorrhagic shock. And so we have our traumatic shock patients, which also includes patients who are in traumatic peri-arrest or arrest, and we'll talk about some of the cardiac arrest criteria. We have our gastrointestinal bleeding, our obstetrical bleeding, so our postpartum hemorrhage, and we also have our pediatric patients who would need blood, again, from a similar constellation of problems, but mainly traumatic injuries. So what are our criteria going to be? So when you're taking care of a patient who's sick, the big picture here is if you're looking at a patient and you say, that patient looks sick and I think they're bleeding, you're probably right. Your instinct is very, very good on this, and you guys are very good at understanding who the patients are who probably need blood. But we need to capture that into some kind of an objective criteria, and these are the criteria that we're going to use, and these are based on best practices from other pre-hospital systems and from the military. And so for adult whole blood, basically the patient first off has to have no objections to getting the blood. So that's one of our contraindications, that the patient has religious or other reasons that they don't want to have the blood. But they just need to have any one of the following. Either a systolic blood pressure of less than 90 or less than 100 if you think they may have a traumatic brain injury. They need a slightly higher blood pressure to maintain perfusion to that injured brain. We're going to talk about the adult shock index, which is your heart rate over systolic blood pressure. That needs to be above 0.9. If you want to do some extra math, and maybe we can get a calculator put into HandTevi in the future, but one thing people are looking at as well is a modified shock index, which takes the mean arterial pressure over the heart rate, and the cutoff for adults for that is 1.3. If the patient has a sustained end-tidal CO2 of less than 25, that's a criteria, and that's a marker for acidosis. That's a marker for the patient having lactate from that end organ dysfunction, making their blood acidotic, and so they're going to be breathing faster and blowing off their CO2 in order to compensate for that. So that's a measure for another shock measure that applies to our traumatic shock patients. And then also, if we have a traumatic arrest patient that we're going to work and they're either the arrest occurred less than 15 minutes prior to arrival, or if they have PEA but have a narrow complex with a rate greater than 40, then those patients are probably not really in arrest. They are just very, very low blood pressure with still having cardiac activity. And they need volume, they need resuscitation in order to survive. And so those would be another indication. If we look over on the other side, we have our pediatric whole blood criteria, which is the same, no stated objections, and obviously that would be the parents stating the objection because they would be the ones consenting with the child. And you have your hypotension for age with the different ranges here, and that's something you can look up in HandTevi as well, and there's a table on the protocol. Or the pediatric age-adjusted shock index, so less than 6 years old or equal to 6 years old is going to be greater than 1.2, 7 to 12 greater than 1, and then over 12 they just have the adult criteria. By the way, you'll find we're going to make some laminated cards, and this will be part of the protocol set as well. And in HandTevi, we actually are going to have a chart for you to look up the shock index, and there will be 3 charts, one for adults and one for each of the age cutoffs, where you can basically see which patients are going to have that shock index above the cutoff. One thing to keep in mind for both of these shock index concepts is that, especially for adults or 7 to 12, if the shock index is greater than 1, it's definitely going to be greater than 0.9. And so a shock index of 1 is where the heart rate is the same as the systolic blood pressure. So any patients you have where you think they might be bleeding and their heart rate is sustained higher than their systolic blood pressure, they are definitely in a shock state and it would be a candidate for blood. The children also have the end-tidal CO2 less than 25 and the same traumatic arrest criteria. Again, shock index is our heart rate divided by our systolic blood pressure. Our adult cutoff is greater than 0.9. It's hard to do that math. We don't want you doing math in the pre-hospital setting, certainly not when you're taking care of a critically ill patient, so we have the charts to refer to. But the quick back of the envelope math is if the heart rate is greater than the systolic blood pressure, you know they're above 9 because they're above 1. Here's an example of the charts that we're going to look at. So these will be laminated and available and also available in HandTevi. So this is the 6 and over with the 1.2 and greater cutoff. This is our 7 to 12 with our 1 or greater cutoff. And then here's our adult shock index. So over the age of 12, it's going to be 0.9 and above. Now, when we're giving blood, we have to be watching for transfusion reactions. One of the things that we're going to do, which is unusual for us, is we're going to be needing to get getting a temperature on all of our patients before they get blood. And I know that's something we don't normally do, but it's actually a requirement of the blood transfusion rules by the FDA and the American Association of Blood Banks. You need to get a baseline temperature. And that's going to be part of how we watch to see if the patient has a transfusion reaction. And so there's a couple of different transfusion reactions out there. I don't want you to hang up on the names because in the protocol we've captured what the different criteria are, but there's basically transfusion-associated circulatory overload, which is basically just a fluid overload, like a congestive heart failure sort of picture. That's really going to happen only when we get into some really in-hospital levels of transfusion of multiple units of blood. Very rare for us to see that in the pre-hospital setting. There's also a transfusion-related acute lung injury, which is more of an inflammatory process. That is possible for us to see. They can have an allergic reaction to the blood or things that are in the blood. That can be shown as an elevated temperature. Also, if for some reason bacteria have been growing in the blood when it's in storage, which again is very, very rare, the byproducts of that bacterial growth can cause a fever when it's injected into the patient. So we'll watch for that. There are acute hemolytic reactions where the red blood cells are breaking open, or the patient's red blood cells are breaking open from antibodies inside the transfused blood, or that reaction to bacterial growth that if the blood has somehow gone bad, which again is very, very rare. But those are the things that we're looking for. Also, there's a context issue here. So the blood transfusion reactions are something that are really fairly easy to see when we're talking about the typical patient getting a unit of backed red blood cells in the hospital, where they're a little anemic, they're otherwise stable, they're sitting in a hospital bed. They transfuse the patient over an hour or so they're checking vital signs regularly over that hour for any changes. These are going to be things that are going to be very hard for us to notice in the pre-hospital setting. First off, by definition, any patient that we're giving blood to is sick and they're going to have unstable vital signs and they're going to be in shock. So that is the shock component as a measure of transfusion reaction isn't super reliable because the two overlap. And then also some of these other ones, they happen over time or they happen with greater volume of transfusion. Also, our requirements are going to be a temperature every 5 minutes after that initial baseline, and generally we'll be able to get that blood into the patient within 5 minutes. So usually we aren't going to be seeing the second temperature in the course of giving the transfusion. It'll usually be a temperature we're going to check afterwards because it'll be within that 5-minute cutoff, and we're going to be getting this blood into patients very fast. So what are we going to look for? This is a cutout of the draft of the transfusion reaction protocol. We'll have a whole package of these new protocols that we'll roll out as part of the training once these are all finalized. And so again, does the patient have signs of transfusion reaction? And just starting off the bat, like the signs and symptoms of hemorrhagic shock and transfusion reaction overlap. Also, don't miss other causes of shock. Because this patient's having difficulty breathing, hypoxia and things, don't miss tension pneumothorax, don't miss airway problems, or simple things like the tank run out of oxygen or something like that. Make sure that we're looking at other causes as well and not just anchoring on the blood and the transfusion reaction. What are our specific findings? These are the things that if this happens to the patient, it's generally from a transfusion reaction. We can count on that. So basically, if the patient gets a temperature above 38 C or greater than 1 degree C from the initial temperature, that's likely a transfusion reaction. Certainly if they're getting hives, itching, angioedema or flushing, wheezing, sudden shortness of breath, or new back, flank, or IV site pain unrelated to whatever they had going on as their traumatic injury or other cause of bleeding, those are going to be fairly convincing that we're dealing with a transfusion reaction. Things that are more nonspecific is if they have new or worsening low blood pressure, elevated heart rate, elevated respiratory rate, out of proportion to whatever their blood loss issue that's going on. And these ones, again, can be very gray. Is the patient just bleeding more and getting sicker, or are they having a reaction? If there's a sudden desaturation with no mechanical cause found, no respiratory cause found, that would be concerning. Or if the patient's getting better and then just suddenly starts to crash. Those are things that are more nonspecific but would lean us towards having a transfusion reaction. So what do? If it's a mixed picture, stop the transfusion and reassess. There's very low cost to pause the transfusion, but if you miss a reaction and continue to transfuse, it's just going to get worse. And a patient who's already in traumatic shock, that's going to increase their mortality significantly. Look for other causes: pneumothorax, airway breathing issues, tamponade. What else could this be? Don't anchor on the transfusion as the cause. Make sure you're keeping your mind open that it could be something else too. And then if another cause is identified and corrected, you can resume the transfusion. If it's just that the patient was desaturating because the oxygen tube came unhooked and you hook it back up and they're better, obviously that's not a transfusion reaction, that's just a mechanical issue. But otherwise, what are you going to do? You're going to stop the blood transfusion, but you're not going to discard anything. You need to keep all the gear because all that gets tested by the blood bank in the hospital. We're going to support our ABCs. We're going to give high flow oxygen. You're going to resuscitate as per the hemorrhagic shock protocol, which has IV fluids in there as well, not just blood. And then if it's a taco volume overload kind of picture, then we're going to discontinue those fluids. But again, that should be pretty rare in our setting because we're not going to be getting that many fluids on board in these patients with our short transport times. If it is an allergic or anaphylactic type transfusion reaction, we're going to go right over to Denver Metro Protocol 4090, which has IM epinephrine, eventual push dose epinephrine, and aggressive volume resuscitation, just like they're in anaphylactic shock from anything else. We disconnect the blood tubing, we're gonna flush the IV, and then start IV saline through a regular drip set. And we're gonna keep all of the tubing and all the equipment that was involved with the blood, so that the hospital can test those for contamination or other things that they test for. And then after that, we're going to continue to monitor vitals every 5 minutes. Heart rate, blood pressure, SATs, respiratory rate, end tidal CO2, and then don't forget temperature, temperature, temperature. That's going to be a peculiar thing with the blood protocols. We're going to be following the temperature because that's a core part of the transfusion reaction issues. What else can be going on here? So additional treatment options. So what about TXA? So we're going to roll out TXA as well, probably even have TXA in the field before we have the blood. And so the indications for TXA are going to be exactly the same as blood, except there are a couple of contraindications. Obviously, if they're allergic to TXA, we're not going to give it. If it's more than 3 hours after the injury or an unknown time of injury, we're not going to give it. TXA actually causes more harm than good after 3 hours. And then actually an interesting thing that's come up in the last few years is TXA probably causes more complications than it does benefit in GI bleeding. It's a different kind of bleeding. It's a slow bleed. It usually doesn't have an acute start time. It's just we have an acute time when we notice it because the patient vomits blood or has blood in their stool. But generally they've been bleeding for longer than 3 hours when we see it. Another key thing is TXA is not compatible with blood or blood products. It's not really compatible with a lot of other medications either. So generally we want to get a second line, or after the transfusion is done, if we still are taking care of the patient, you can start TXA after you flush the line. What's the adult dose? 2 grams over 20 minutes for trauma, 1 gram over 10 minutes for postpartum hemorrhage. It's a different dose that's been studied in postpartum hemorrhage rather than trauma patients. It's lower. And again, for GI bleeds, we're not going to give it. Pediatric dose, we cover for all ages. It's 15 mg per kg over 20 minutes. Maximum dose, 1 gram. And that is, those doses will be in hand heavy for you. We're going to get this in a bag, so if you're given 2 grams, it's going to be 2 bags. So 1 bag over 10 minutes and then repeated over 10 minutes. Versus postpartum hemorrhage, they're just going to get the 1 bag, and obviously for pediatrics, we're going to draw up the volume we need and give it. Some other things. So you guys, I'm sure, have seen some of the data about lactated ringers being slightly better in trauma than saline. Basically, both of our salt-based solutions are not great in trauma. They are better than nothing. They are essential to try to keep that blood pressure above 90, but we don't want to give excess saline or excess lactated ringers. You'll notice we don't have lactated ringers. One of the problems with lactated ringers is it contains some calcium, and it makes it incompatible with a lot of different medications that we carry. So because of the compatibility issues, we stuck with saline, and the really big thing is that we're not giving massive volumes of saline to hemorrhagic shock. So the possible harm between saline and lactated ringers is really very small as long as you're not over-resuscitating. You'll see in some protocols that actually any hemorrhagic shock patients are getting calcium. That's a bit of a combination of a couple of different issues that, for example, in a mass transfusion protocol in the hospital where we're giving 5, 10, 15 units of blood products, we'll give calcium because the anticoagulant that I talked about before that's in the bag that keeps that blood from clotting in the bag, it usually works by binding up calcium. And so when that anticoagulant gets into the patient's body, it binds up a little bit of calcium. 1 unit, 2 units, no big deal. We start to think about this after about 5 units of blood where we're replacing the calcium that's being bound up by the anticoagulant. So again, not an issue for us. At most, these patients are going to be getting 2 units of blood. Most of them are going to be getting 1, if that. So this is something they can follow up in the hospital after checking the patient's actual calcium levels too, which we can't do. So no benefit for calcium in the pre-hospital setting with short transport times with small amounts of blood like we're giving. So you won't see a calcium protocol in our hemorrhagic shock protocol. What equipment? We're going to have coolers that are going to keep this cool. And again, this is going to be the responsibility of the SAM officers and the out-of-class SAMs, and we're going to have a whole detailed training for them so they know what to do for the documentation and everything. But basically, this is a durable, portable cooler that allows us to have this blood outside of the hospital, basically changing out the inserts periodically to keep it cold, and then it has monitoring, and it's connected to the internet, does all these things to tell us if the temperature ends up dropping, because that cold chain storage documentation is important for blood. Then we need to warm it back up again. So we don't want to give cold fluid if we can avoid it, and so we have the Q and Flow warmer. We're going to go over that hands-on. It has 2 parts. It has one part that is very expensive and is reusable, so don't throw the electronic part away. And then it has a one-time use only block that has the heating elements in it that warm up the blood. And so we'll, again, work on that later on and use those. That's going to warm it up. I'll say this again, if for some reason the blood warming device isn't working, it is better to give cold blood than to not give any blood at all. It is best to give warm blood. But if you basically can't get it working or it errors out for some reason, then just go ahead and give the blood. But the blood always has to be given through filtered IV tubing. It can't be given through regular tubing because little tiny blood clots need to be filtered out, and particulates need to be filtered out, or else those will end up basically in the patient's lungs, causing little tiny pulmonary emboli. And so those are something that's very important. We're going to use the LifeFlow infuser. Again, more hands-on on this, and the trigger device is reusable, but the tubing is replaceable patient by patient, and this allows us to give IV and IO blood very, very fast with high flow. Also, the Y-type blood tubing in a pressure bag is an acceptable way to do this as well, so we'll have that as a backup plan. But again, we need to have that filter that you can see in the picture there that catches those particulates and any little tiny blood clots, so we're not transfusing those into the patient. Let's talk about consent. So consent, blood brings up some important consent issues, and I'm sure you're aware of some of those. Some people have some very strong religious beliefs about whether or not they can have blood, and we need to be cognizant of those. Also, the kind of consent we have to do is informed consent, and we don't do a lot of that in the pre-hospital setting. We do a lot of asking permission to do things, but we're assuming when the patient calls us for help that they want the kind of help that we bring as a EMS system. Because this is special, we have to actually do formal informed consent, which includes going over the risks, the benefits, and the alternatives, and documenting those things and communicating what those are. So again, this is straight out of our consent flow chart protocol and procedure. Is we're going to confirm the patient has decision-making capacity. Then we talk about risks, benefits, and alternatives in terms the patient can understand. And then this has the required steps and suggested scripting for this. I know you guys don't do this regularly. I know you're not going to be doing this often, and so we want to make sure that it makes that we have a script, and we'll have that laminated as well of what these risks are, so you're not having to remember these things at 2 o'clock in the morning. So what do we do first? Just going straight to 0030 in Denver Metro, does the patient have decision-making capacity? There is a little bit of something that I want to bring up, that suicidal ideation removes their capacity to refuse a life-saving intervention. But if the patient's verbal, you want to tell them, hey, given this suicidal ideation, I'm obligated to basically provide this life-saving treatment, but be practical. They may lack the capacity to refuse, but if that's going to escalate them, get you in a fight, and to the point where you have agitation and need for sedation, we don't want to be sedating hemorrhagic shock patients. So be practical. If you can do this without escalating, that's great. If you can't, defer the transfusion until the patient gets to the hospital where they're in a more stable spot. So use your judgment on that one. Now, if the patient does have decision-making capacity, we go through the consent process. So we have a time-critical script. The patient is dying in front of us. I think you have life-threatening bleeding. I recommend a blood transfusion. Do you have any objections to getting a blood transfusion? That, for an acute setting, patient crashing, not really being able to communicate with us well, but still having decision-making capacity, you can use that. If there's more time, we have a more detailed script, which covers things like minor transfusion reactions, like a rash or a fever, not life-threatening, but minor things. Those happen about 1 in 1,000 transfusions. The dangerous life-threatening transfusion reactions are about 1 in 100,000, so very, very low risk. And a blood-borne infection is somewhere around 1 in 1,000,000 transfusions. So the blood that we're giving is very well screened for infectious stuff. And if the patient refuses, you want to acknowledge why that is and document that without being confrontational. We're not interrogating the patient. We're not trying to change their strongly held beliefs. But a good script for that. I absolutely respect your decision to refuse a transfusion. I just want to make sure we're on the same page. Can you tell me in your own words what you think the risks are of going without the transfusion? Make sure they understand that what they're refusing is a life-saving intervention, and capture that and document it, but then also respect that decision. Now, because we're using Rh positive blood, there is a small chance that that can cause problems with a future pregnancy for girls and women of childbearing potential. So not just women of childbearing age, but kids that might have babies in the future. And so the scripting for that is, hey, as someone who may become pregnant in the future, there's a small additional risk that this blood transfusion could cause complications with a future pregnancy. Not saying they can't get pregnant, but there could be complications. The risk of a serious complication is less than 1%, or about 1 in 300 future pregnancies, and is much smaller than the risk of not getting blood today. And again, this is from alloimmunization, which we'll talk about in later trainings. But in general, when we talk to mothers who have been alloimmunized, and basically have had that one rare complication, they actually say that they prefer to have had that life-saving transfusion despite that risk, even though they ended up the ones having the risk. So this is something we want to disclose, but it's not a reason to not give blood to a hemorrhaging patient. But we certainly, need them to understand that risk and accept that risk as an individual. And again, if they are an Rh negative woman of potential childbearing, future childbearing potential, the hospital sometimes will treat that with something called RhoGAM. There's some gray area about whether or not the RhoGAM's beneficial, so we're deferring to the hospital on that. And then if they have future pregnancies, then they would have the maternal fetal medicine specialists follow that along and just see how the baby's doing and make sure they can mitigate those complications as they come up, again, off into the future. So there's a plan for that, not something that we need to address, but we do need to address that additional risk. Pediatric patients, if the parent's not there, then this is implied consent, just like any other pediatric care. And if they are present, you can send them the same way. Also the same deal if it's a child, a future childbearing potential, you want to address that. So you just use the same scripts, but change the wording to apply to the child instead of the patient themselves. And then document. We need to document what kind of consent was obtained. Was it informed consent or was it implied consent? Obviously, all of our unconscious patients or unresponsive patients, our altered patients, those are going to be implied consent. But we need to document one or the other. If they refuse, we need to document what disclosures were made, what their understanding of the risks were, that teach-back response, and the patient was informed that they may change their mind at any time. So if someone refuses it, you need to tell them, hey, if you change your mind, let me know, because we can change course here. If it's a religious or personal objection, document it and document whether or not the patient eventually accepted or declined the transfusion. Logistics issues. So we want to make sure the whole blood administration doesn't significantly delay transport. So how does that work? So first off, we want the SAM officer who's having the blood, they're going to come in with the patient and they're going to be responsible for the blood administration, but the attending paramedic is still going to be responsible for the overall care. If the SAM officer is en route, the general rule of thumb is if you can hear the sirens from the SAM vehicle, stand by on scene until they get there. If they're further out than that, either arrange for an intercept on the way to the hospital or arrange them to meet you in the hospital parking lot. Or if it's just they're not going to be able to make it, just move fast to the hospital, do the blood alert, resuscitate with saline as per protocol. If the intercept can happen, which is expected but infrequent, we want to make that handover very quick, get the SAM officer in the back of the vehicle, and then keep going. Now, if the SAM is meeting you at the hospital, you want to get that blood started in the bay and be giving it while you're walking in. And the reason for that is it can take 10 minutes or more after arrival in the trauma bay to get that first drop of blood in, because they have to do their ordering and all their documentation stuff and get the blood warmer and rapid transfuser up and running. That takes time, and frequently they're in the middle of many, many other things going on. So there can be a significant delay after arrival at the hospital to get the hospital's blood on board. So you really want to get that first unit on board early on. The SAM is going to be responsible for the documentation of the transfusion process within the PCR, but the attending paramedic will be responsible for the rest of the care. If it's mutual aid, you guys would document the overall care and say, hey, blood was given by the Thornton SAM or the Adams County SAM or whoever else, and that responding SAM would complete blood documentation in their own agency PCR so that the reporting happens at the state level. So more training to come, and thank you for watching this video. We'll be seeing you in person when we're going over this stuff, and we will have a bunch more training and a bunch more practice and scenarios going forward. Thank you very much.